as you know, anemia represents about 75% of low-risk MDS, and the main treatment is red blood cell transfusions. But in the two last decades, you had several trials evaluating ESAs in lower-risk MDS, leading to two phase 3 trials, Epoetin and ARCAD trials, randomizing Epo-alpha and darbepoetin versus placebo in low-risk MDS patients. These two trials yielded positive results for erythroid response and red blood cell transfusion independence, and therefore you have the EMA authorization for erythropoietin alpha in low-risk MDS patients with anemia and with a serum EPO level less than 200 units. So in a clinical practice, you have several kinds of erythropoietin alpha, beta, glycosylated form of EPO, darbepoetin. And the 2 decades of studies on ESAs led to the following recommendations I would suggest for the use of erythropoietin. So higher doses of erythropoietin seems to be interesting in terms of response rate. So about 30,000 units per week to 60,000 units per week for erythropoietin beta, 40,000 units per week to 80,000 units per week for erythropoietin alpha, and 100 microgram to 300 microgram per week for darbepoetin. So higher doses seems to be interesting. There is no difference between the different forms of erythropoietin or darbepoetin. And early introduction of ESA seems to yield higher results. Therefore, you should not wait for high transfusion burden patients to introduce ESAs. The earlier you introduce ESA after MDS diagnosis, the higher you get a response rate.